I'm Adrienne Paul. I'm the neonatologist and member of the ICONS team, and I'll be introducing our speakers from Washington University in St. Louis to talk about treating alcohol use disorder in pregnancy. Kevin Zhu is an assistant professor of psychiatry at Washington University in St. Louis with a dual appointment in the School of Public Health. He's a psychiatrist and health services researcher who is a core faculty member at Washington University Center for Advancing Health Services Policy and Economics Research. His research uses administrative claims to evaluate the impact of mental health and drug policies with a focus on birthing and reproductive age people. Carolyn Carey is an MD MPH candidate at Washington University in St. Louis, and her research focuses on the intersection of reproductive health and addiction medicine with a particular focus on treatment access and outcomes among pregnant and postpartum individuals with substance use disorder. She plans to pursue residency in OBGYN with the goal of integrating clinical care and research to improve health outcomes among birthing people with substance use disorders. And I will turn it over to them to tell us about treating alcohol use disorder in pregnancy today. Thank you so much.
Okay, thanks so much for having me here. Does everyone hear me okay? Fantastic. Okay, so yeah, thank you for this warm welcome to Vermont virtually. And big shout out also to Mishka Turplin for connecting us with this wonderful group. I just wanted, before I start, I'm really honored to be joined today by Caroline Carey, who's an MD and PhD student at WashU. As you've heard, Caroline is headed for a career in academic OB and is exceptionally talented in health services research. And so the way we're going to do this is I'm going to take you through the first part of the talk, which is a bit about the practical challenges of diagnosing and treating alcohol use disorder on the ground. And then Caroline will present some data from a recently completed review of clinical practice guidelines internationally on the treatment of alcohol use disorder in pregnancy that I personally wasn't really aware of myself until we did this. And so it's some late breaking data that is going to be published soon, later in this year. And so in terms of disclosures, next slide, please. My work is funded by NIH and the American Psychiatric Association. And I think another important disclosure I would just want to add to the slide is I've never been pregnant before, nor have I experienced a substance use disorder. And so I'm really taking this perspective as a clinician and also a public health scientist. And so if anything I'm saying based on my experience here, kind of looking at the data from a 30,000 foot view and from my experiences working as a doctor is off base, I'm really welcoming that sort of feedback. And so I'm so excited to have these conversations with everyone here today. Next slide. In terms of the agenda today, I'm particularly happy that this session today and this whole series of talks is focused on screening. In the first part of the talk, I'm going to talk a little bit about some clinical concepts and frameworks that puts the challenges of screening into perspective. So some questions I'm going to consider, and really go through is, why is treating and identifying alcohol use disorder in reproductive age people so hard in the first place? So we're going to talk a little bit about diagnosis, also harm reduction, and the landscape of comorbidity that really complicates the management of alcohol use disorder. Really going to put on my hat as a clinician in this section and kind of building off of some of the things we talk about in my work serving as the rotation director for substance use disorders in the psychiatry residency at WashU. And then Caroline is going to walk you through what the actual clinical practice guidelines say, or maybe more importantly, don't say. So next slide, please. So by the time we're done today, I'm hoping you'll be able to describe what's out there in terms of the international practice guidelines on this topic, and more importantly, identify the gaps in our clinical guidelines, as well as understand why medications for alcohol use disorder and pregnancy are barely getting prescribed and what that means for our patients. Okay, so next slide. So first section of our talk here is why screening and diagnosis isn't straightforward. And I'm going to zero in on a concept called the continuum of use. And so you might think, right, screening is the easy part. Well, that's what I used to think for some time, and often trainees have that idea because we have screeners, we have the DSM criteria, audit scores, all that stuff. Next slide. And so this is something that trainees at WashU, residents and medical students often bring up when we're talking about alcohol use disorder, broadly speaking, right? They're like, we have these DSM criteria for substance use disorders, which many of us are familiar with. They seem simple on the surface. There's 11 criteria. You can count them up. You can get mild, moderate, severe thresholds, right? The thing that makes this hard in clinical practice, which I'm hoping to really zero in on with a series of vignettes up ahead, is navigating the definition of functional impairments. And what I mean by that is to diagnose a use disorder, we have criteria that's been published pretty extensively, right? But the use really has to be causing clinically significant impairment or distress. And that's where it gets really messy. Next slide. And so functional impairments, which is a hallmark of meeting criteria for any substance use disorder per the DSM, is actually not a fixed thing. And so all the time in clinical practice, right, patients and clinicians will look at the same situation and they might see it differently. And so a patient's own sense of how they're doing may not actually line up with what your clinical criteria say. And further, the threshold for what counts as clinically significant impairment can reasonably shift depending on context. And so for a patient who's pregnant or actively trying to conceive, you're no longer just asking about impairments to their life today, right? You're also asking about potential harm to developing pregnancy, which really changes the conversation. And so I'm going to go through a couple of vignettes to really zero in on some of the challenges, at least I face day to day when it's screening and evaluating people for substance use disorders. And so next slide. And so what I'm going to do is, this is really just an exercise that I think takes this material and will hopefully bring it to light. So I'm going to go through a series of vignettes now. So imagine you are an OBGYN clinician who's seeing a 31-year-old person for a routine well woman visit, requesting IUD removal, actively trying to conceive, and in terms of social history, is otherwise healthy, works as an accountant, and reports no significant medical history. Has completed a routine substance use disorder screener, a check-in, which prompted this whole discussion. And the screener, turns out, flagged for daily caffeine use. The person has been drinking 4 to 5 cups of coffee, 5-hour energy drink, PRN, has been drinking since college. Consumption has increased since starting at the current firm, and says that if the morning coffee is skipped, there's headaches and some irritability and fogginess. But the key thing here is it's not a problem at all. Reports no functional impairment, doing well at work, relationship is good, managing life well. So just think about this in your head, consider it. What would you document in the electronic medical record here for this case? So just give it a few seconds, and my advice is, let's not think too hard into it. Let's go from the gut. How do you feel? Okay, so just take this vignette, like mentally screenshot it, and don't forget it. Next slide. Okay, so this is the same exact vignette, but I changed a couple of things this time. Instead of caffeine, now we're talking about tobacco. So this person has been smoking a pack a day since age 17. Use has gone up over the past couple of years. Tells you if there's no smoking, there's headaches, maybe feels irritable and restless. It's going to cut down once she's pregnant. and plans to stop when she's pregnant. It's not a problem at all. Work is great, relationship is solid, no functional impairment. So let's look through these lists of labels here. What might you document? Would it be nicotine use, dependence, use disorder, or no diagnosis? And so maybe give it just a few seconds. And what does your gut tell you? Okay, next slide. Now, same patient, same visit, except take everything we just talked about, tobacco, and remove it. And now the screener flags alcohol. And so it turns out the patient has been drinking more than half a bottle each night to unwind. Use has gone up over the past 2 years. There's no shakes, no DTs, no seizures, but she does notice headaches and irritability in the mornings that she does not drink. And she indicates that she's going to stop once she's pregnant. Never missed work. Relationship is going well. Not a problem at all. I'm fine. No functional impairment whatsoever. And so the question is, in this case, what would you document? Alcohol use, alcohol dependence, alcohol use disorder, or no diagnosis. And so again, try not to go too deep into the DSM criteria. I'm kind of curious, just from your gut, how are you feeling about this? And I have one final vignette. So if you have all these different snapshots mentally, let's move to the final series here. Last slide. Okay, so instead of alcohol, we're swapping this off with cannabis. So the screener flags cannabis. Smoking a gram most evenings, using edibles on the weekends for sleep and anxiety. The use has gone up in the past year. It tells you if she skips overnight, she has trouble sleeping and feels irritable. Plans to stop once she's pregnant, mentions it's not a problem at all. I'm fine. Work, relationships, etc. are fine. No functional impairment. So is this cannabis use, cannabis dependence, cannabis use disorder, or no diagnosis? And so go to the next slide. So these are things I think it would be really interesting to have this discussion later. And I kind of wanted to just set the stage. So some things to consider here. Part of the reason we did this exercise is how do these vignettes differ? Because structurally, the way we wrote these are, they're structurally pretty similar, but I wonder if it also felt different from you. And so some questions that you may want to consider are, does actively trying to conceive change your threshold for diagnosis? And also what happens when you and your patient see it differently? Next slide. So a point I wanted to make here with these vignettes is, this tension where a patient and a clinician see situations differently comes up a lot, especially as a substance use disorder clinician, but it can come up in every corner of medicine too, right? I think two familiar examples you might think of is, if someone's been on clonazepam for years, developed tolerance, taking more than prescribed, cognitive effects, you suggest a taper, but then they state that, I would be worse off without it. It's the only thing that helps me with anxiety. You can swap clonazepam for oxycodone. You hear the same thing all the time. And so the takeaway I wanted to just kind of make here is the continuum of use is really tricky when it comes to diagnosing substance use disorders, including alcohol use disorder. And in practice, when we encounter situations where someone screens positive, where the diagnostic criteria is really lighting up, and then you hit this functional impairment question, everything often slows down when we're trying to, do screening and diagnosis, at least speaking personally here. And I'll be the first to say, as a mental health clinician, who's using these vignettes all the time to train residents and medical students at WashU, the field of psychiatry has also not reached a solution on this. And so there are definitely situations where you may need to even defer diagnosis. Next slide. So the second theme I wanted to just briefly highlight before Caroline starts her section of talk is barriers to harm reduction. So let's say we've had this diagnosis conversation and your patient is still drinking. What do we do? And this is really where harm reduction frameworks can be useful. Next slide. And so something that Caroline will really be zeroing in on that's really important is that the public health messaging on alcohol and pregnancy is it's unambiguous, right? Like no amount is safe, but the clinical reality is that not every patient is going to stop drinking. And for those who continue to use, harm reduction gives us a framework for meeting people where they are and trying to reduce harm short of full abstinence. But here's a catch. Speaking as a public health, wearing my hat as a public health scientist, harm reduction also requires risk thresholds. So to tell a patient what safer looks like, you got to have data on what less harmful actually means. So next slide. And so we've had several breakthrough papers in the alcohol and cannabis spheres, which we do not really have, which we do not have for alcohol and pregnancy. And so on the left, you can see that the WHO has published risk levels, and the alcohol field has started moving towards a definition of recovery, which includes reduced heavy drinking, not just abstinence. And as of this past year, there's been some glimmers happening in cannabis, data emerging on what constitutes safer cannabis use short of full abstinence. Next slide. But for pregnant and reproductive age people, such data on risk thresholds are far more limited. And so translating what we know from the general population into clinical guidance for birthing and reproductive age people and parenting people is still an open and active area of research. And I really like citing this phrase in this paper on cannabis here. If you don't have data on risk thresholds, it's really hard to do harm reduction work. And so we're kind of left navigating a space without a clear public health message. No amount is safe, right? But the reality people might still be using, and we don't have the evidence base to tell people what the less harmful path actually looks like. Next slide. The third and final theme I just wanted to zero in on before we get into Caroline's section are some emerging epidemiologic trends, which everyone here is probably very familiar with already, which is alcohol doesn't exist in a silo, comorbidity, and the polysubstance landscape. Next slide. And so without getting into this data too much, but this is from the NIH HBCD data. And I think a really important thing to zero in here is comorbidity is not the exception. It is the norm when it comes to people's substance use disorders. And as of some of the more recent data from the study, it seems that alcohol nationally outnumbers opioids by itself in terms of perinatal exposures. And the other thing I think that's important from this data is, whenever I see a patient with alcohol use disorder, the question I often ask myself beyond a review of systems for alcohol is, what else is going on that's highly treatable? Because there's often multiple other conditions going on, right? Other substance use disorders, other mental health conditions. This issue of comorbidity seems obvious, but actually in the addiction research literature, this is historically not talked about enough. And you might be surprised by how many studies in the addiction world look at alcohol use disorder in isolation, like opioid studies that exclude anyone with alcohol use disorder, or depression studies that exclude people with alcohol use disorder, or alcohol studies that exclude people with other SUDs. Next slide. And so the fact that alcohol is so comorbid with other substance-related problems means that we really need to be paying attention to what's happening with other substance use disorders, not just alcohol in isolation. And so if we talk about opioids as an example, we may have heard the narrative, and it's not wrong that opioid deaths are going down in many parts of the country, which is really positive news. But the trend is not necessarily translated the same way for birthing people in many parts of the US. And so again, when your patient comes in with alcohol-related issues, it's also important to think about what's happening with opioids on the list. And so with that being said, next slide, I will transfer this over to Caroline. Some points I just wanted to zero in on from the prior slides is diagnosis is a bit harder than it looks. Harm reduction is limited. in the absence of risk thresholds when there's birthing people using alcohol. And comorbidity is ubiquitous. And so we're wondering, what do the guidelines say about this?
Hi, is everyone able to hear me okay? Okay, amazing. Thank you so much again for having us. Before I get into what current guidelines recommend, it's worth briefly grounding. Next slide, please. It's worth briefly grounding our discussion in what we know about alcohol use disorder during pregnancy and why this clinical context is especially complex. Alcohol use disorder is the most common substance use disorder worldwide and in the United States. Alcohol use in pregnancy is widespread with global prevalence of about 10%. And English-speaking countries report particularly high rates, as you can see from this graph from a 2017 meta-analysis. And that found that prenatal alcohol use was as prevalent as 41% in the United Kingdom, 36% in Australia, 27% in New Zealand, 15% in the US, and 10% in Canada. In the US, prenatal alcohol use rates and binge drinking rates have been rising, and alcohol is now the most common prenatal substance exposure in the US, overtaking cannabis, tobacco, and opioids. Next slide, please. Beyond pregnancy-specific data, we're seeing a broader shift with the longstanding sex gap in alcohol-related emergency and patient admissions in the US narrowing. Taken together, these trends show that alcohol-related morbidity in people of reproductive age is becoming increasingly relevant. Next slide, please. The health impacts of alcohol use are well established. Alcohol use disorder in particular carries serious risks from premature mortality to chronic conditions. And when alcohol is used during pregnancy, its effects on both the parent and fetus are widely recognized and extensively documented. It can lead to severe maternal morbidity, spontaneous abortion, stillbirth, and intrauterine growth restriction. And importantly, it can also result in fetal alcohol spectrum disorder, a condition that's associated with neurodevelopmental impairment, congenital anomalies, poor growth, and additional cardiovascular, GI, and mental health comorbidities. Next slide, please. To illustrate how the risks of alcohol use during pregnancy are typically communicated to patients, I've included this infographic from the American College of Obstetricians and Gynecologists. The main message emphasizes that drinking during pregnancy can have serious and potentially devastating effects on fetal development, and those are outlined in the graphic. Next slide, please. This is the final section of that flyer. It states that alcohol-related birth defects are completely preventable. While that is biologically true, alcohol exposure can be avoided, this wording doesn't fully acknowledge the challenges many people face in reducing or stopping alcohol use during pregnancy. And while the flyer emphasizes that these outcomes are preventable, it provides very little concrete guidance for individuals who may struggle to stop drinking, beyond suggesting they speak with their OB, attend Alcoholics Anonymous, or call the SAMHSA treatment referral line. As we'll discuss, this misalignment between strong abstinence counseling and few treatment options is quite common. Next slide, please. So, given what we know about the effects of alcohol use in pregnancy, the question becomes, how do we address it? As suggested by the lack of guidance in the previous slide, there's limited evidence to inform clinical decision-making for alcohol use disorder during pregnancy, despite the substantial disease burden. And this is reflected in treatment patterns. Most pregnant patients with alcohol use disorder in the US and Australia, for example, do not receive medication for alcohol use disorder or MAUD. Treating alcohol use disorder in pregnancy isn't straightforward and comes with a unique set of clinical considerations. MAUD, such as acamprosate and naltrexone, are effective and well tolerated in the general adult population. However, their safety and effectiveness in pregnancy are largely unknown, and strategies for balancing maternal benefit with fetal risk are poorly characterized. And as such, for pregnant people who are on MAUD, discontinuation often occurs during the first trimester, and the effects of discontinuing MAUD in pregnancy isn't something that we have a firm understanding of. Next slide, please. So let's say a pregnant person with AUD does stop drinking. What happens next? When people stop drinking during pregnancy, there are still hurdles to cross. During early recovery, patients face a range of mental health challenges, things like emotional dysregulation, anxiety, and depressive symptoms. Because access to perinatal mental health specialists is often limited, much of this care typically falls to OBGYNs. Clearly, AUD and alcohol use in pregnancy are complex issues that require specialized, coordinated care. Next slide, please. This brings us to the objective of our study and how we approached it. Next slide, please. We set out to take a closer look at major clinical practice guidelines, which I'll refer to as CPGs, from around the world, and we wanted to see how they address alcohol use and AUD during pregnancy, especially the use of medications for AUD. We use the AUD cascade of care framework to guide our work, looking at how these guidelines offer recommendations across key stages of treatment, specifically diagnosis, engagement, initiation, and retention. Next slide, please. So next, I'll talk about how we actually approach the study. We used the PICAR framework to structure our review of clinical practice guidelines. Our population included pregnant people who use alcohol or have an alcohol use disorder, and we looked at interventions for AUD, including medications, psychosocial approaches, screening, and brief interventions with or without a comparator. For content, we focus on guidelines from professional medical organizations in English-speaking countries, published since 2014, that address AUD treatment during pregnancy. And for each eligible guideline, we examine its attributes and recommendations, looking at whether and how it provided guidance on screening, managing, or treating AUD during pregnancy. Next slide, please. So here's how we identified and selected the guidelines. First, we used PubMed and major guideline databases using terms related to substance use, AUD, pregnancy, and CPGs. 2 reviewers screened abstracts and covidence, and we included full text if they focused on substance use or mental health in pregnancy and were meant for clinicians caring for pregnant patients. And then in a second phase, we searched gray literature like professional society and government health department websites to capture any additional guidelines. Next slide, please. For data extraction, we recorded each guideline's characteristics, focus, and any recommendations on AUD treatment in pregnancy. Then we used the AgreeRex framework to assess the quality of these recommendations, essentially looking at how clear, relevant, and actionable they were. And that is overall how we identified, extracted, and assessed the guidelines in our review. Next slide, please. To give you a visual overview of that process, this slide shows our Prisma diagram. In phase 1, our search of PubMed and major guideline databases yielded 829 results. After removing duplicates and screening abstracts and covidence, we ended up reviewing 32 full-text articles that focused on substance use or mental health in pregnancy and were intended for clinicians caring for pregnant patients. And then in phase 2, our gray literature search added an extra 216 additional records for review. After completing both of those phases, we had a total of 18 CPGs that met our inclusion criteria and were included in the analysis. Next slide, please. This table summarizes the 18 guidelines we reviewed. Many came from the US, with others from Australia, New Zealand, Canada, the UK, and international organizations like the WHO. And they targeted a mix of specialties from general practice and psychiatry to OBGYN, addiction medicine, and family medicine. Next slide, please. So now I'm going to move on to what the 18 clinical practice guidelines actually said about alcohol use and AUD in pregnancy. I've organized the findings according to the stages of the care cascade, so I'll go through each stage one by one, and then at the end, I'll show a slide that kind of brings them all together side by side. Next slide, please. I'll start by discussing their general approach to alcohol use in pregnancy. Nearly all the guidelines, all but one, discuss the risks of alcohol exposure during pregnancy. And similarly, almost all, except for 2, recommended counseling pregnant patients on alcohol cessation. And about 72% of the guidelines specifically mentioned screening pregnant patients for alcohol use. Next slide, please. Next, looking at how the guidelines addressed clinical management of alcohol use during pregnancy, about 61% of the guidelines mentioned referring pregnant patients to some form of treatment for alcohol use. A third of the guidelines included any discussion of harm reduction, such as strategies for reducing alcohol use during pregnancy. And half provided guidance on treating alcohol withdrawal with medication during pregnancy. So this stage of the care cascade is not as well represented among the guidelines as earlier stages, like describing the risks of alcohol use in pregnancy, screening, and counseling for cessation. Next slide, please. Next, we looked at how those guidelines define and conceptualize alcohol use disorder. Just over half, about 56%, explicitly used the term alcohol use disorder at least once, rather than referring only to alcohol use or people who use alcohol. And about 39% of the guidelines clearly distinguish between treating alcohol use disorder and treating alcohol use that doesn't meet diagnostic criteria for a substance use disorder. Clear terminology is really important because it influences how clinicians approach diagnosis and treatment for alcohol use disorder in pregnancy, as Dr. Xu was discussing. Next slide, please. Lastly, we looked at the specific recommendations these guidelines made for treating alcohol use disorder specifically during pregnancy. Fewer than half, about 44%, mentioned the use of medications for alcohol use disorder during pregnancy, and only half of those went on to provide an actual recommendation for or against their use. Of those, 3 guidelines actively recommended against using MAUD in pregnancy, while only 1 explicitly supported it. In addition, just 3 guidelines mentioned any form of psychosocial intervention for alcohol use disorder during pregnancy. As you can see, this stage of the care cascade was by far the least representative of the 4. Next slide, please. So now we've walked through how these 18 guidelines address alcohol use and AUD in pregnancy step by step across each stage of the care cascade. On this next slide, I've pulled together all of those pieces so you can sort of see the picture, full picture side by side. And this really helps highlight where the strongest guidance exists towards the beginning of the cascade and where the gaps start to emerge further along the cascade towards treatment. Now that we've looked at the overall patterns across the cascade, I'm going to show a few representative excerpts from the small number of guidelines that explicitly address MAUD in pregnancy to illustrate how they approach the issue in their own language. Next slide, please. So here are a couple of representative quotes from the 4 guidelines that addressed MAUD during pregnancy and took a fairly equivocal stance. Several, like the WHO and the National Drug and Alcohol Research Center guidelines, acknowledge that medications such as disulfiram, naltrexone, and acamprosate exist, but they emphasize that their safety and efficacy haven't been established for use in pregnancy. The general message from these CPGs was that decisions should be made on a case-by-case basis, weighing potential risks and benefits for each patient. Next slide, please. In contrast to the guidelines that were more neutral, 3 guidelines explicitly recommended against using medications for alcohol use disorder in pregnancy. The Joint International Guideline from the World Federation of Societies of Biological Psychiatry and the International Association for Women's Mental Health stated that due to the low level of evidence and an unfavorable risk-benefit ratio, pharmacologic treatment for maintaining abstinence should not be used during pregnancy. And similarly, the American Psychiatric Association guideline noted that because of limited data on potential fetal risks, non-pharmacologic intervention should be used preferentially for treating alcohol use disorder in pregnancy. Next slide, please. Finally, the only guideline that offered supportive language around using medication for alcohol use disorder in pregnancy came from the Society of Obstetricians and Gynecologists of Canada. This guideline cited emerging evidence from opioid use disorder treatment suggesting that naltrexone may be safe in pregnancy and advised prescribing it only when the potential benefits outweigh the risks. Similarly, it noted preliminary evidence for acamprosate safety in pregnancy with the same cautious recommendation to use it only if the expected benefit outweighs possible risk. So overall, this was the only guideline that offered any positive recommendation for pharmacologic treatment during pregnancy, while most others either avoided a recommendation or explicitly advised against use. Next slide, please. Now that we reviewed what current guidelines recommend, let's consider what these findings mean for clinicians caring for reproductive age patients with alcohol use disorder. Next slide, please. To summarize, there was a lot of guidance around alcohol use in pregnancy itself, with nearly every guideline advising screening all pregnant patients and counseling them not to drink. And some even offered detailed instructions, such as repeated inquiries about alcohol use or use of validated tools like the audit. But when it came to alcohol use disorder, the guidance really dropped off. Most CPGs stopped at suggesting a referral to specialty care or managing acute withdrawal, with very little direction on how to actually treat AUD during pregnancy. And this pattern existed across specialties, including OBGYN, psychiatry, and addiction medicine, despite the expectation that different disciplines may provide a more balanced distribution of recommendations across the treatment cascade. This pattern, in which each specialty is deferring treatment to others without providing clear management guidelines, likely is contributing to low rates of AUD treatment in pregnancy. Most guidelines not only avoided discussing MAUD, but also few mentioned specific psychosocial interventions. When guidelines did provide recommendations on psychosocial treatment, they were often very general. The guidelines rarely specified treatment modalities like cognitive behavioral therapy, motivational enhancement therapy, or 12-step facilitation. And they also didn't provide guidance on treatment settings, whether therapy should be individual or group-based, what session frequency should be, treatment duration, or adaptations for pregnancy-specific concerns. And importantly, no guideline addressed whether trauma-informed approaches should be incorporated or provided direction on the role of mutual help groups such as Alcoholics Anonymous during the perinatal period. Next slide, please. In terms of strengths and limitations, I'll start by emphasizing that the absence of treatment recommendations in many of these guidelines doesn't necessarily mean they were low quality. In fact, most of the clinical practice guidelines scored quite well on dimensions like applicability, values and preferences, and feasibility, so they're actually quite strong in terms of structure and relevance. This real issue seems to lie in the evidence base itself. There simply isn't enough high-quality data to support more definitive recommendations for treating AUD during pregnancy, which makes it difficult for organizations to take a stronger stance. As for limitations of our own review, we only included English language guidelines from predominantly English-speaking countries. That said, it's worth noting that the WHO guidelines are designed to be globally applicable in many countries that don't have extensive national guideline infrastructure, including those that have high rates of perinatal alcohol use, such as Brazil, rely heavily on WHO recommendations as the foundation for their national policies and their clinical protocols. So while our review primarily captured guidance from high-income English-speaking nations, the gaps we identified in WHO guidance really do have implications that extend far beyond those populations. And finally, our focus was specifically on pregnancy, not the postpartum period, which is another key window for addressing alcohol use and supporting relapse prevention. Next slide, please. What really stood out to us is that most of the guidelines acknowledge just how limited the evidence base is when it comes to using medications for alcohol use disorder during pregnancy. Because of that, they often recommend individualized decision-making rather than firm or directive guidance. However, most of these guidelines don't provide parallel discussion of the well-documented and severe risks of untreated AUD, both for the pregnant person and for the fetus. No guideline offered a detailed framework for how to actually weigh the uncertain risks of continuing MAUD against the known substantial harms of untreated AUD during pregnancy. And in practice, this uncertainty leaves both patients and clinicians facing some really difficult choices. For people with AUD who are planning a pregnancy, there's a constant weighing of risks, the risk of continuing medication versus the risk of stopping it. Many patients end up discontinuing psychotropic medications during pregnancy out of concern for fetal exposure, but in other chronic conditions through shared decision-making, patients often do remain on medications with known fetal risks, for example, antidepressants or opioid use disorder medications, when the maternal benefits are considered to outweigh potential harms. By contrast, current guidance on AUD in pregnancy offers very limited support for similar shared decision-making approaches. That leaves clinicians without a clear framework for balancing maternal benefit against possible fetal risk. And while the data we do have on our medications for AUD, particularly our naltrexone and acamprosate, don't show evidence of harm, it's still a very under-researched area. Meanwhile, the harms of untreated AUD, both for the parent and infant, are very well established. Altogether, this really underscores the need for more research and for clearer evidence-informed guidance going forward. Next slide, please. So stepping back, what we found is that there's a clear misalignment in this space. On one hand, there's strong consensus. Nearly every guideline emphasizes the importance of universal alcohol screening and counseling for abstinence during pregnancy. And as I mentioned earlier, these guidelines are generally rigorous and well-developed. But despite that, there's very limited guidance on what to actually do when a pregnant person has alcohol use disorder, how to manage it, what treatments to consider, and how to support recovery safely. That gap really highlights how clinical practice has outpaced the evidence base, leaving clinicians to navigate these decisions without much formal direction. Next slide, please. Based on what we've seen in the clinical practice guidelines we reviewed, it's not surprising that discontinuation of MAUD is nearly universal, leaving many patients without evidence-based treatment during a critical period. Next slide, please. Looking ahead, there are three clear next steps. First, CPGs need to place greater emphasis on shared decision-making, acknowledging the uncertainties we just discussed, and ensuring that patients are informed partners in navigating those risks and choices. Second, since there isn't yet a consensus on the use of MAUD during pregnancy, we really need better guidance on what works best psychosocially during this period, how to support patients, which interventions to use, and how to tailor them for pregnancy. And third, we really need to strengthen the evidence base for medication treatment of alcohol use disorder in pregnancy. That means both prospective research and systematic evaluation of outcomes among people who continue MAUD during pregnancy. So future guidelines can move from conscious ambiguity towards concrete evidence-informed recommendations. Ultimately, we clearly still have much to learn about how to best treat alcohol use disorder during pregnancy, and closing that gap will be essential to improving outcomes both for patients and their children. Next slide, please. We're really grateful to all our co-authors on this work. I'm especially grateful for Dr. Shu and our other PI, Dr. Martin. Also, we wanted to acknowledge the grants that supported this work that are listed on this slide. Next slide, please. These are some of our selected key references. Next slide, please. References continued. Next slide, please. And with that, thank you so much for listening, and we'd be happy to take any questions.
Questions, I invite the listeners to come off mute and come on camera if you want to ask questions and or put any questions in the chat. And I did see some commentary on our local data in Vermont in the chat about maternal morbidity and mortality data in Vermont supporting the concerns about polysubstance use and comorbidity. I might also invite anybody related to that work if you would like to speak to that. Please feel free to come off mute.
This is Katie Leffel. I just had put in the chat, and Julie had put the legislative report for maternal mortality in the chat. I think that what we see in maternal mortality oftentimes includes alcohol use, but isn't the primary driver of death, of course, because they're a young population. But the polysubstance use piece is really important. And we've talked a lot in the Perinatal Quality Collaborative and the maternal mortality world around how do we have better conversations with people about pre-pregnancy use and indications around what might happen postpartum with, relapse into use and return to use, even if they are reporting not using during pregnancy. So like kind of those navigating those conversations in a more helpful way for pregnant people. And then the other thing I like to really bring up every time we talk about alcohol use in particular is our PRAMS data, which our PRAMS coordinator at the state did a little bit of a deeper dive into the population who reports higher rates of drinking alcohol during pregnancy, including that third trimester, versus the populations that report higher rates of being counseled against alcohol use in pregnancy. And what she found is that the birthing people who report higher rates of alcohol use are the oldest birthing population, the most highest educated, and private insurance. And the population that reports the higher rates of being counseled against alcohol use are exactly the opposite: Medicaid insured, lower education rates, and the youngest population. And so, we see some disconnect there in the data around the people that report use versus the people that are getting the counseling in pregnancy the most consistently, enough to remember it, in that year postpartum at some point. So I think that gives us a direction of where to go around alcohol use and how to have better conversations with patients around it. So I'm going to mute myself. I just saw that you talked about local data. So the PRAMS report, I think, doesn't have the data around counseling that I just talked about. I think that was something she did out of interest, but I don't know if it's in there. But
hello, Jennifer Auletta here. Can you hear me okay? Adrian, okay, thank you. I'm from Central Vermont Medical Center, and I'm the perinatal mental health clinician and resource coordinator here in our OB/GYN and midwifery office. I wanted to tack on with what Katie was saying in terms of thinking about how medical providers are being trained or supported to have those types of conversations. And I was curious if in any of the articles that you reviewed, if there was any indication of physician or midwifery or those types of providers having confidence in being able to have those conversations outside of what you were noting as very basic sort of warnings without a lot of other tangible backup around stresses and why someone might be using habit versus dependence and those types of things. So I'm just curious about provider training in having those conversations in any of the articles you read.
Yeah, that's a great question. So one thing I wanted to just also highlight that Caroline mentioned, but it's kind of an interesting thing about all these guidelines is you might think that these guidelines, there's not a whole lot of information being provided on whether to give medications or, counseling, right? It seems like there's not a whole lot of ground covered besides basic, don't drink kind of messaging. But Caroline also mentioned that the guidelines were high quality mostly, which is kind of feels like a little bit of a contradiction. And I think that's something I just wanted to explain that was really fascinating about this project. Some of the guidelines that we reviewed were like 300 pages long, actually. And you might think, like, how is that possible? How do you go through 300 pages and there's like interviews with like people with like lived expertise and like local like clinicians and like all sorts of interviews being done, and it was very like some of these were extremely comprehensive, only to conclude at the end like we don't have anything to guide whether to prescribe or not, and we don't have any knowledge on what type of psychotherapy is the best. We don't know what to do during the 4th trimester. And so to answer this really good question, Jennifer, I don't think my understanding from looking at these guidelines is the field is not really at a place to provide in-depth training on how exactly to do this counseling or how to have these shared decision-making conversations. Some of it may have to do with the absence of people of funded studies in this important area to help move the field forward. Historically, this has been very much overlooked by our federal funders that have prioritized other topics, which has created a bit of a research gap. But it's not that these guidelines themselves were sloppy. They were so in-depth, but only to conclude that there are some serious problems in this field. Okay. Julian, should I have you run, or Adrian, should I have you run the show with the questions that are rising?
Do you want to just read the question in the chat and go through it?
Sure.
Yeah.
I am curious about what people are willing to report about use versus not sharing true consumption. This seems impossible to track. I have some, yes, yeah. Yeah. So this is where I'm really curious about people's experiences too. I'm so happy to hear these perspectives because this is something I wear multiple hats. On one hand, I'm a researcher who works with diagnostic data in the medical chart and claims all the time. And then there's the experience of being a clinician on the ground as someone who's putting in these diagnoses and seeing what is diagnosed versus isn't diagnosed. And it's really interesting because part of the reason I went through the vignettes early on is I suppose over time I have become more wary of diagnostic data and whether alcohol use really means use versus use disorder, and whether someone who doesn't have it in the charts like truly doesn't have a substance related problem that wasn't diagnosed for various reasons. I've seen, at least I'm curious to hear other people's perspectives here, really. But sometimes people struggle, but I struggle with, is this really functional impairment. Should I put this in? It's going to pop up this day and age, people, especially if they are using Epic and have my chart, they're going to see what their doctor put down. And there have been some really challenging conversations about what constitutes something worthy of a diagnosis versus not. And I think it's created such a bottleneck with regards to working with public health data, at least at a national level.
Please chime in.
Yes, hi, my name is Kristen Morrow. I'm a recovery coach from Turning Point Center of Central Vermont. Obviously, I can't speak on the diagnostic part. I am not a clinician, but I am a person with lived experience. And I find that people are actually most transparent about their use when in a group of other women. I think support groups are amazing. I don't know how much, that will help with the diagnostic aspect, but you really see them opening up when they're able to share that with each other and share those experiences.
Yeah, no, I'm so glad you shared that. And I think it's helpful to contrast these conversations people are having in support groups with what's actually what's happening in the clinic room, especially if it's like rushed and it's just like a screener being used. I was pretty humbled while doing this study because we were so excited to have one of our co-authors, Dr. Dougal, spent some time actually working at a Native American reservation for several years in South Dakota. And he brought a really valuable perspective actually to this particular project that we were doing that Caroline presented. Because I learned, someone who's practiced at academic centers, that there are many settings where you may not have a psychiatrist present or a mental health specialist present. And then there's often just this like really, this dependence on clinical practice guidelines or going through algorithms or very like rushed formulaic ways of doing screening when we don't have experts available. And so, I think that's just an interesting contrast, right? If someone comes in with a complicated mental health history or has trauma, and this is kind of met with like a really rushed algorithm or really rushed screener, and the person asking the question may not necessarily have the expertise to really take a deep dive and understand what's going on. Like, do people want to open up in that sort of setting?
This is Katie unmuting again, but one of the things that I've been thinking about recently is the way that we approach intimate partner violence with our nurse home visiting program in Vermont. Is that we have to do a screening for the federal funders, but we also do a universal approach where we hand out resources universally. We have conversation universally. We hand out the resources. And I think with perinatal substance use, there's so much fear around we're being reported and disclosing use and being a bad mom if your child has, it's like all the stuff that I think the screenings are important. And I think we want to have those conversations, but also just having that conversation around pre-pregnancy use, impacts on your life. And here's a resource if you or anybody in your family, and just like a connection to Vermont Help Link or something like that. Like, just everybody should get the same spiel around, like, this is really common. It's a really hard struggle. You might not want to talk to me about it right now, but here's a resource if you want to think more about it. And just really normalize those conversations, because I think people aren't necessarily going to disclose use if they, everyone feels judged, or fearful. So.
And I think that's such an important point. And Caroline, do you want to weigh in on what you also found in the guide? Like, I don't think there was a whole lot in the guidelines on like trauma-informed approaches either at all, right?
Yeah, not at all. That I think was kind of the one of the main things that we found out in terms of like very little about psychosocial interventions and very little about trauma-informed care too, which was definitely disappointing.
You saw Caroline's slide with from ACOG, which it's pretty it's pretty a bit of a hammer. Don't drink, and there is a lot more of that in terms of the public messaging, rather than what's approaching things with a lot more tact.
On the resources we use with intimate partner violence, the handout that we have is a little booklet, and it just talks about like what's a healthy relationship, and think about that. And so I think that's a good conversation to have about alcohol, because a lot of people, I have my own lived experience with alcohol use, and you don't realize you have a problem until at some point you do, and then you look back and you think, oh right, it was there all along. So like those kind of conversations around like maybe they're not recognizing it, but like here's a healthy relationship with substances, or that kind of thing. So I think lots of work to do around that we communicate with substance use.
Yeah, absolutely. And I think it just contrasts that, right, with the conventional so-called psychosocial intervention that was being advised across the guidelines was this vague referral to psychosocial treatment, or referral to therapy, as Caroline was highlighting. And in my perspective as a clinician, seeing these guidelines, it's like the guidelines themselves have all this work put into it. They're pretty high quality, but the culmination is a vague, like, you should just go to therapy. And there's no consideration of, talking about how to incorporate it into a treatment plan, healthy relationships, or, coping with other fourth trimester challenges. And so to me, the effect of some of these recommendations is frankly rather anemic.
Any other last questions? We probably have time for one more. Or last comments from Dr. Zhu and Caroline.
Thank you. Thank you for inviting us.
Thank you for coming and joining us. This has been really just helpful to hear the scope of opportunity in this field. And we really appreciate you joining us for the morning.
Yeah, thank you all so much.